has been posted as required. For those of you who are not familiar with me, my name is Lori Follett. I am the CCBHC program specialist at Nevada Medicaid over CCBHCs. Reminding everyone to go ahead and mute yourselves as you come on in. Okay. We're going to go ahead and get started. I will do my introduction one more time for those of you who just bounced in. My name is Lori Follett. I am the CCBHC policy specialist for Nevada Medicaid for CCBHCs. Today we are going to go over CCBHCs and the expansion of them in Nevada Medicaid. Before we get started, we'll do a little bit of general housekeeping. Remember that general public comments, no action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111, and when prompted, provide the conference ID of 406-018-45#. Then you may press 5 to raise your hand during the public comment periods to provide your comment. Comments will be limited to 3 minutes per person. Persons making public comment will be asked to begin their statement with their name for the record and to spell their last name. Those who wish to provide written comment may submit their comment via mail to 1100 East Williams Street, Suite 101, Carson City, or via email to doccontrol@dhcfp.nv.gov. We are going to move on now. Let me find my slide deck. Okay, you should be seeing the front page of my slide deck at this point. You have joined the public workshop for the Certified Community Behavioral Health Center expansion with the Division of Healthcare Financing and Policy. As I mentioned before, my name is Lori Follett, and I am the CCBHC Policy Specialist here at Nevada Medicaid. We want to thank you for taking time out of your day to join this discussion. The CCBHC is an acronym for Certified Community Behavioral Health Centers. You will hear me say that a lot today. We're going to discuss the expansion coming to Nevada in 2024. I do work with a talented team to bring CCBHC to Nevada and its recipients. I will bring some of this team into the discussion as we go through this today. If you do have questions as we go through, you may enter them in the chat. However, we will have public comment periods. So at this point, if anyone has a public comment before we get started, go ahead and raise your hand and we will address that now.
Wait. You never know what's going to happen. Okay.
Okay, hearing none on the public comment side so far, there will be another opportunity for public comment at the end of our presentation. Today, we will go through a brief history of the CCBHCs, outline who can become a CCBHC, a summary of services. We'll go over the proposed expansion model and enrollment criteria. We will discuss rate methodology and the steps needed to become a provider. Finally, we will have a question and answer opportunity. The history of CCBHCs in Nevada include, essentially, this is a Substance Use and Mental Health Services Administration demonstration project. Nevada took part in that project, and we have been within that, building that CCBHC model since 2016. I think I forgot to push record. me see here. Oh, no, I did it. Perfect.
You
Sorry.
got it.
All right. Initially, there were 24 states that were awarded the planning grant for the demonstration program. Out of those 24 states, Nevada was chosen as one of the 8 states awarded to move forward with the 2-year demonstration project. Where are we now? We currently have a state plan amendment pending with CMS. This SPA, as they're called, corrects some flaws that we had with rate methodology and quality of incentive payments. During the 82nd legislative session, the Medicaid budget was expanded to increase the capacity for Medicaid to add CCBHC providers. As of July 1 of 2023, Nevada has moved all providers under state plan, and we do not have any providers operating under the demonstration authority at this time. So who can become a CCBHC? Under Section 233 of the Protecting Access to Medicare Act defines that a CCBHC must be one of the following: a nonprofit, part of a local government, behavioral health authority, or an entity operating under the authority of Indian Health Services. There we go. The CCBHC model is a heavy lift, and it is essential that prior to investing time, energy, and money, providers understand their requirements. This model has been proven effective, and there is significant support for CCBHCs nationally. And as noted, in Nevada, with support from our legislator providing approval for additional funding this last session. Please note that services must be provided for all ages, from child to advanced age, and every age in between. The services that a CCBHC must supply to their community are the following 9 core services. These can be provided directly or through formal relationships with designated collaborating organizations. Crisis services, treatment planning, screening, assessment, diagnosis, and risk assessment, outpatient mental health and substance use services, targeted case management, outpatient primary care screening and monitoring, community-based mental health care for veterans, peer family support and counseling services, and psychiatric rehabilitation services, plus assertive community treatment. With CCBHC being a heavy lift for everyone, including providers, state, and contract teams, we have prepared a pre-enrollment checklist. I will go through the checklist and how the business process will flow. We won't begin enrollment of this provider type until January 1st of 2024. We have drafted this pre-enrollment checklist to guide you through the process. The team will break this down on the following slides. We will have a training session on this process and the CCBHC criteria November 30th, 2023 at 9 a.m. We have this scheduled for 3 hours. Notice of this training will come out via the Medicaid listserv and through our partners at CASAT in the coming days. This training will be a requirement to begin the pre-enrollment process, and proof of the training will be required. If someone chooses to enroll as a CCBHC after November 30th, this training will be available, recorded, and again, proof will be required of that training. We intend to go live with this enrollment as of January 1st, 2024. For current CCBHCs, the provider must not have a statement of deficiency or a plan of correction in place for the last 6 months prior to enrollment. Providers must be enrolled as a Nevada Medicaid provider type and billing for a minimum of 6 months prior to the application date. As previously discussed, the CCBHC is a heavy lift, and as is the enrollment and billing of Medicaid. The history our team has had with working with grantees with CCBHC funding, the successes we have seen are those that meet this criteria. If a provider is a CCBHC and decertified as a CCBHC, they must wait 2 calendar years to reapply to the provider type. The need for an independent NPI for data and tracking purposes is required. And your electronic health record, or EHR, needs to be able to accommodate multiple diagnoses, codes, and the ability to shadow bill many CPT and HCPCS codes. Shadow billing is defined as the process of billing the daily code for a CCBHC, that is the T1040 code, as the primary, and the other codes off the allowable services grid for all services used on that date of service. The prospective provider must also provide to the state the name of the EHR that they use. Providers must review and be familiar with the CCBHC Medicaid Services Manual, Chapter 2700, Chapter 400 for behavioral health, and Chapter 2500 for targeted case management. Providers also need to understand Medicaid Services Manual 100. They need to review and be familiar with the state plan section pertaining to CCBHCs, the billing guide and allowable services for provider type 17188 or the CCBHC, the SAMHSA criteria for to understand the 9 core services plus assertive community treatment. Providers must supply the needs assessment used to determine the community need in their area. They need to designate the catchment area the CCBHC will provide services in. Review the CASAT Technical Assistance Guide. And there's also an HCQC application. Within that application, providers would need to show evidence of zoning approval, the current business license, their lease agreement, their partnership agreement, if applicable, articles of incorporation for corporations only, or an article of organization for LLCs, their governing body bylaws, their certification from the fire marshal, their facility floor plan. Providers will need to show documentation that all of these items that fall under number 4 are in place. The personnel checklist and staffing plan. They will need to provide the state with the CCBHC's policy and procedure manual that they will need to draft, and they need to provide the details of their governing board. It's essential new providers need to review the pre-enrollment criteria, review and gather that needed information. And once you've determined that you meet or exceed all that criteria, you would need to submit that to CCBHC at dhcfp.nv.gov. The materials should be submitted on individual documents, numbered and labeled to align with the pre-enrollment checklist. The state lead will review and reach out to the provider with any questions, and the state will likely need a minimum of 4 weeks to provide that feedback, depending on how many applications are received. Now, the great question everyone asks is, how much are you going to get paid? So CCBHCs run off a PPS system, or a prospective payment system. This is a daily rate, and this is done by billing the T1040 code, which I previously mentioned, and then billing all of your shadow billing codes and the CPT HCPCS codes for the recipient for that date of service. Those shadow billed codes are billed with a Q2 modifier. This modifier will set the rate for all those shadow billed codes to 0. Only one PPS or T1040 code can be billed per date of service per recipient. New CCBHCs will start with a PPS rate equal to the average of all current CCBHCs across the state. Currently, that rate is approximately $213. After 2 years, the CCBHC will be required to go through a cost reporting process with the state's actuarial vendor to establish that actual rate. This process is required every 5 years after the initial rate setting. So 2 years after you become a CCBHC, you have to go through a cost reporting process that will establish your permanent rate. Every year after that, CCBHCs are given the Medicare Economic Index adjustment. So the rate will be adjusted based on Medicare Economic Index, or MEI. And then within 5 years after that first rate was set, we would require that to be done again. CCBHCs also have the opportunity to earn quality incentive payments. These payments are paid to CCBHC providers at the year end as specified in the state plan. For the first 2 years, these are paid based on reporting. The actual metrics do not need to be met. The provider does need to work with our data team to be sure that they are ready for reporting by year 3. I do want to point out, as I mentioned in the beginning of this presentation, our state plan amendment is currently pending CMS approval, and the information I'm providing you here is based on that SPA that's pending approval. So this is all systems go so long as CMS signs it off. So we don't see any issues with that, but if something should arise, this presentation could change slightly. For year 3 and beyond, the quality measures can be paid up to 15% of the total PPS rate. For year 1 and 2, my apologies, for year 1 and 2, it's 10%. For year 3, it can go up to 15% of the total PPS payments. And this quality incentive payment for performance is calculated by taking the sum of the total facility-based bundled rate payments made to the CCBHC in the performance period, multiplied by 5% if the full and complete data sets are submitted, an additional 1% for each of the 6 required measures attained, plus 2% of all the total facility payments if the plan all-cause readmission measure is met, and 2% for the state-directed crisis measure. It would total 10% for that section and 5% for the data set, total of 15%. So the steps to become a CCBHC: watch or attend the CASAT training that's going to be coming to the end of the month, review and complete the pre-enrollment, submit that pre-enrollment documents to CCBHC at dhcfp.md.gov. Documents need to be individually numbered and named based on the enrollment checklist for ease of review. The state will review that submission. We will contact the provider and advise of next steps. And after initial review, the provider will be directed to start the enrollment process if they meet that minimum criteria. Okay, I went through that fairly fast. Does anyone have any questions? Let's see, there's something in the chat. I can already see it. Okay, that's just Sarah. Okay, Chris Chris Murphy, you can go ahead and unmute and ask your question.
What date was that training? Was that November 30th?
Yes, sir.
Thank you.
You're welcome. Any other easy questions like that would be appreciated. Could you please go over shadow billing again? So shadow billing is, in its simplest form, the CCBHCs will bill a PPS rate or a daily rate under the T1040 code. All other services that were provided that day, any other CPT or HCPCS codes that were utilized, the ones that are allowable can be found on our allowable services grid through our fiscal agent. Those need to be billed in the other claim detail lines, and they're billed with a Q2 modifier. That modifier sets those codes to 0. And ultimately, that shadow billing is utilized for data collection and the quality incentive measures. All of those things come into play. But they're set to 0, and it really gives us a lens as to what's going on in the CCBHCs without having to physically pull records and review or be actually on site. Let me know if you have any other questions, let me know. Let's see, there was
Lori, there was a question prior to that too.
Yes. I missed that one. It came through at the exact same minute. Can a provider maintain a 17-215 and have a 17-188 as an additional provider under a separate MPI? Sarah, if you want to take that, but I believe they can, but I don't know why you would.
Exactly. I think I would agree with that. all of the codes that are available under a provider type specialty, provider type 17, specialty 215 would be available under the CCBHC as well. And then there is, I can't remember, Lori, if you mentioned it, under this new CCBHC provider type, there are no prior authorizations for services because the model functions a bit differently.
Chris, do you have another question, or is your hand still up from the first time? When you say
Sorry, I left
services,
my hand up.
okay, no worries. When you say services are set to 0, would the MCOs process and pay the Medicaid H0035 is not listed on the allowable services grid? The rate that is higher than the PPS rate, which is why we're asking.
Sorry, I put two together. I was writing one thing and responding to another thing. This is Angela from WestCare. So the first question was, when you say all of the CBT HCPCS are set to 0, do the MCOs process and pay the rate associated with the service, and that T1040 that you're talking about comes in later paid by the state, or how does that payment process work?
So the MCO contract currently reads that for CCBHCs, when they bill that, when they bill out to the MCOs, they must pay the minimum, they have to pay that PPS rate. They cannot pay less. So that eliminates the need
That
for
answers
wrapping.
my question.
Okay.
Yes.
Did
The
you have
other
another?
thing I wrote in there was about H0035, which is the PHP. That's not listed as an allowable service, and that rate is higher than the PPS rate. That's why I was asking about the PT 17215 and the PT 17188.
Sarah, do you want to answer that?
I was trying to pull up the allowable services grid because I do believe H0035 is part of it and but I have to confirm, it's been a while. Providers can either, let me get back to that. Let me look at the allowable services grid. Sorry, Angela.
No problem. Thanks so much.
Yeah.
Dr. Woodard, where would an applicant find guidance on the requirements to define a catchment area? We are not defining what they're calling their catchment area. We're asking them to define what's needed in their communities, and we will assess at the application. Any
Okay.
other
Sorry,
questions? Go
going
ahead,
back
Sarah.
to Angela, going back to your question, H0035 is part of the allowable services grid. I understand your train of thought under the 17215, but that is an allowable service. So if CCBHCs perhaps have a substance use treatment focused partial hospitalization program, that would require certification through SAPTA. And then if there was that mental health focused, that is available under provider type 14s. But the service itself of PHP is available under the CCBHC. So you would get that PPS rate for that service.
I'm adding the CCBHC email to the chat in case anyone comes up with a question after we close out this workshop. Go ahead, Dr. Woodard.
Thanks, Lori. I had asked a question in the chat. Are FQHCs eligible to enroll as a CCBHC if they've been providing behavioral health services, but only under the FQHC and not another behavioral health provider type like a PT 17, 215, 14, or other?
If a FQHC has been providing behavioral health services under the Medicaid model, I would think that would also comply with that requirement.
Thank you.
Mm-hmm. Sorry, I missed that one in the chat. So You give it a few more minutes of awkward silence to see if anyone else has any questions. Again, the referenced training that will occur on November 30th should be coming out soon. I will also have our listserv folks should send it out to that mode as well, but that will be put on by CSAT. There's another question in the chat that I missed. Can the owner of a for-profit provider 14 start a nonprofit for the purpose of this, getting credit for years of past Medicaid billing? Sarah, do you have an opinion on that?
Yeah, so because the requirement is to be a nonprofit agency for the CCBHC, but maybe this provider has been a provider type 14 for the past 10, 20 years. Would that suffice? And I think, Lori, on your pre-enrollment checklist, you kind of left it open for discussion on your previous requirements as a Medicaid provider for kind of these one-off situations that we're talking about. And
Right.
as Lori had mentioned, it becomes under review with our CCBHC team. And all of that information is what helps us make those decisions moving forward. So great question.
You're welcome. And sorry I missed that. Luckily, someone pinged me, told me it was up there. That went very fast. So I'll give everyone just another minute or so to come up with any questions. This would also be an opportunity if you have public comment of any kind, we can take that as well before we close this out. And again, we did record it and it will be posted as soon as the folks that have the power to do that can get it up. You have to have, yes. So the question in the chat is an EHR company mandatory? I don't know about company, but you do need to have an EHR, electronic health record, to be able to provide the data needed for the quality metrics, as well as for the ability to do the shadow billing port. I'm not sure how you would do that otherwise. Mark?
Just a note on that. You need to have a HIPAA high-tech compliant EHR to be able to do this. So that's just to let you know that it's not just something you can do internally. It has to be a HIPAA high-tech compliant health electronic health record.
And for everyone on the phone, Mark Disselkoon is with our partner at CSAT, and he will be part of that training on the 30th. Definitely a valuable member of our team. And Sarah Dearborn is also, I didn't introduce anybody, in the behavioral health unit at Nevada Medicaid, and she is our behavioral health chief. I did that totally backward. With the application, would it be a problem if we had our own homegrown EHR? I think Mark already kind of touched on that. It just has to hit all the HIPAA compliance privacy. Does the state?
There was a time that you could do a homegrown system, but then you have to go through and make sure it meets all of the high-tech HIPAA requirements, and it's very complicated to do that and expensive. So that's why I think most people go with companies that specialize in it.
And would the EHR need to have interconnectivity with the DCO? Based on the Medicaid chapter, it says the claims would need to be submitted on behalf of the DCO. It would need to have, we have not had many take up the option of using a DCO at this point. However, there needs to be some interconnectivity.
Yeah, the DCO has to have access to your EHR to do all of the documentation within your EHR, and that's really the goal there.
And a DCO is a designated collaborating organization. The quality metrics can be found on our website. dhcfp.nv.gov under programs and CCBHC. I will point out that SAMHSA is revising the quality metrics at this time. There was another question I missed back here. Does the state have a set number of CCBHCs they will approve, or is this a true open enrollment where all qualified organizations will be credentialed as a CCBHC? We don't have a set number at this point. We have walked away from the waiver, which would limit our enrollment. However, all providers that come to us looking to enroll would have to meet the enrollment criteria. Is there a special billing rate when EHR is created in-house? The PPS rate is the PPS rate. And as mentioned before, all of the details that Mark mentioned about EHRs need to be in place. Did I miss anybody? Scrolling back through to make sure I didn't miss anybody. I don't think I did. Oh no, there's, okay. Give it just another minute. And let's see if I can get this in the chat. I can get you guys the link to our program website. That's the link to our program website. At the bottom of the page, you'll find quality incentive payment methodology and a link to that. Another note of a requirement that comes with that data is there are customer satisfaction surveys that have to be completed and submitted. Those would be explained also a little later on as we go into more of the details of what a CCBHC looks like. I do encourage you prior to meeting, coming to that meeting on the 30th, that you can review some of those information for quality incentive payments, for the SAMHSA criteria, the Medicaid chapters that we referenced. All of those are important when it comes to understanding how a CCBHC works on a daily basis. If you have any problems finding any of that information, we do list it in the handouts from this meeting, but you can feel free to reach out to me. The email here again is ccbhc@dhcfp.nv.gov. Okay, I don't think I see any more questions in the chat. No one is raising their hand. And again, if something comes up in the meantime that you have questions or something comes to mind, you can feel free to reach out. We're absolutely here to disseminate the information and help you where we can. I want to thank you guys all for coming today. If there's any other questions, like I mentioned, you can definitely email those in either to myself or to Doc Control, which is also noted in the agenda, and we will get back to you on those. We had a great turnout, so I'm very excited about that. And are you asking the current cost for CCBHCs in Nevada, or are you asking the current daily rate, average daily rate? I'm not sure I understand that question. So Trey, if you want to come off of mute or.
Sure. I know there's CCBHCs in Nevada, and there's a grant to support their creation. Yep. I'm wondering if there's any estimate of the general cost to get all this stuff in place to qualify as a CCBHC.
I don't know that I have a pulse on how much it would cost to get it in place. I know that some of SAMHSA does do grants. They do a grant funding cycle. Honestly, they've been doing it at least annually for quite a few years now. Those grants can run anywhere from $1 million to $2 million over a course of a year or 2 years. So Those are the grants that I know of that have been put forth. The state of Nevada itself does not have any grants to do that. It would also depend on what you already have in place. Like if you're already a behavioral health provider and you already have a lot of these things in place, then you're not accruing no expenses for those. So I don't know that I have a true pulse on what it would cost to set one up.
Thank you.
You're welcome. Okay, let's try it one more time. Does anyone have any final questions before I stop the recording and end the workshop? Okay, I'm going to go ahead and stop the recording. And